morning, dear audience. Thank you for joining me on my PhD research entitled The Application of Enhanced Recovery After Surgery Protocol to Improve Patient Outcomes After Surgeries. Let me introduce myself. I'm András Czébely-Lénárt. I'm a second-year PhD student and an obstetrics and gynecology resident at the Department of Obstetrics and Gynecology, Semmelweis University. My supervisor is Balázs Lindner, and my scientific methodology supervisor is Szilárd Báncsa. Our vision is that every patient will get the best evidence-based care before and after surgeries. And to achieve this, our mission is to integrate the newest evidence-based routines into clinical practice. Currently, we are doing two different projects. Let me introduce the first one to you, which is investigating the patient outcomes in bowel resection surgeries with and without mechanical and oral antibiotic bowel preparation. This is a systematic review and a network meta-analysis. Infectious complications are common after colorectal surgeries. The incidence of surgical site infection is between 5 to 20% of the cases, and anastomosis leakage is between 2 to 10% of the cases, respectively. There are two different types of bowel preparation aiming to reduce these complication rates. The first is mechanical bowel preparation, which means drinking large amounts of laxatives to expel fecal matter from the bowel before the surgeries. And the second one is oral antibiotic preparation in order to reduce bacterial load. The proper combination of these two bowel preparation methods remains controversial in bowel resection surgeries. There is not a widely accepted protocol. Hospitals use conventional routines in order to reduce these complications, and that makes our aim is to evaluate the optimal bowel preparation method to be used for elective colorectal surgeries to minimize postoperative complication rates. That arises our clinical question: what is the proper combination of mechanical and oral antibiotic bowel preparation to reduce postoperative complication rates in patients undergoing surgeries with bowel resection? So we are focusing on surgeries with bowel resection, whether the patient had mechanical bowel preparation, oral antibiotic bowel preparation, the combination of these two, or no bowel preparation at all. And we are focusing on postoperative complications such as surgical site infection and anastomosis leakage as key outcomes. Our hypothesis suggests that combining mechanical and oral antibiotic bowel preparation in preoperative routines will reduce the postoperative complication rates in surgeries with bowel resection. Here you can see our domains, the different domains. The first part is for the surgeries itself, and the second part is for the preparation methods. We ended up with more than 20,000 results, and after the full text selection, we could find 89 eligible full texts to extract data from. We have finished our analysis, both of our analyses, the surgical site infection and anastomosis leakage. So let's dive into the details. Here you can see the first figure. It's the odds ratio for surgical site infection based on RCT results. Surgical site infection reduces anastomosis healing and increases septic complication rate. And as you can see, the basic comparator was no preparation, and we are using the different preparation methods comparing to no preparation at all. And as you can see, the mechanical and oral antibiotic bowel preparation shows a significant difference, reducing complication rates. And although mechanical bowel preparation has no effect on reducing complications. You can see that oral antibiotic complications shows a bit decrease, although it's not significant. But if you take a look at the patient number in our studies, it's relatively low. So what we did, we performed a sensitivity analysis, And we also included observational studies results, not just RCTs. And as you can see, raising the patient numbers or the case numbers, we have found significant, mathematically and clinically significant reduce in complication rates with oral antibiotic bowel preparation as well. Our third figure is odds ratio for anastomosis leakage based on the RCT results. Anastomosis leakage is one of the most feared complications because it raises the mortality of the patient after these surgeries. And we can see that compared to no preparation, mechanical and oral antibiotic preparation combined together shows a significant reduce in anastomosis leakage rates. And as we can see, oral antibiotic preparation and mechanical bowel preparation shows no clinical significance. But and after we included the observational studies, we ended up with the same results. The strength of our study is that it shows a comprehensive picture for all types of bowel preparation. We have the largest patient numbers compared to other previous meta-analyses, and the heterogeneity of the illnesses we examined were low because we excluded inflammational bowel diseases. However, our limitations is that there is just a few number of RCTs comparing combined preparation versus antibiotic oral preparation alone. And we could find a lack of information about the surgery types and resection site-specific complication rates. So our conclusion is that mechanical and oral antibiotic preparation used together is the best approach to reduce complication rates, and oral antibiotic preparation also has promising effects. Our implication for practice is that combined bowel preparation should always be used as gold standard. If mechanical bowel preparation is contraindicated, oral antibiotics should be used alone, and mechanical bowel preparation should be never used alone. Our implication for research is that we need to focus on the efficacy of oral antibiotic preparation alone, and we have to get more detailed reporting about complication rates specific for resection sites. Currently, we have finished our manuscript, and I hope that we can publish it in the next few weeks. Our second project is comparing the safety and efficacy between fasting and early oral feeding after bowel resection surgeries. This is a systematic review and meta-analysis. Conventional protocols after bowel resection surgeries entails fasting, administrating only intravenous fluids until full bowel function recovery. However, this ERAS protocol, which is an up-to-date evidence-based protocol system, suggests early oral feeding as it reduces the length of postoperative ileus and the length of stay at the hospital as well. We can see that the resolution of the ileus is shortened in the early feeding group, and the length of stay at the hospital could also be reduced following the early feeding protocol. That makes our aim to investigate the advantages of early postoperative oral feeding. Our clinical question is, what is the optimal timing for first oral feeding after bowel resection surgeries? We are focusing on bowel resection patients after the operation, whether they follow the early oral feeding protocol or the fasting protocol until full bowel function recovery. And we are measuring the ileus, the length of the ileus, and length of stay at the hospital as primary outcomes and postoperative complication rates as secondary outcomes. Our hypothesis suggests that early oral feeding after bowel resection surgeries will reduce the length of postoperative ileus, length of the stay at the hospital, and also reduce complication rates. Our clinical implication is to ensure quicker and safe recovery after bowel resection surgeries. So for summary, the first project, as I mentioned, we would like to submit it by the end of January, and the second project in this year's summer. Thank you for your attention, and for last but not least, a smooth sea doesn't make a skilled sailor. Thanks.
Thank you for the presentation. And I would have just one question to the first project. In the included articles, which was the regular used antibiotic, and could you find any differences in the effect based on the antibiotic?
Usually metronidazole, but there, like most of the RCTs, almost every one of them uses different types of oral antibiotic administration protocol. So we couldn't find homogeneity between the RCTs.
I see, and then you couldn't compare the effects based on the drug type.
Yes, but what we discussed, that it's not so it's not necessary, because they are attacking anaerobe and aerobic bacteria with different regimens, so it doesn't make any difference whether they use metronidazole or other types of.
Okay. Thank you very much.
Thanks.
Thank you for the nice presentation. I also have one question regarding to your first topic, that you mentioned as a limitation that the surgery types, they are not really included and it's hard to find them. But still, do you have any information about whether these patients, they are oncological patients,
yes,
or
most of them
endometriosis?
Yes, for this statement, I wanted to refer about like laparoscopic and open types of that, or laparotomies. But most of the cases were oncological patients. So we focused on mostly rectal and colorectal cancer patients. Yeah.
And in this case, the type of the bowel resection, it was mostly segmental, or I guess there's no discoid resection, or
no,
or
segment resections. Yeah.
Okay, and you think if you would examine separately the endometriosis patient and the oncological patient, would it be a difference in between, or I don't know, like not just the endometriosis, but of course I'm a gynecologist, it's close to my heart.
Well, like, cancer patients are operated by surgeons, so that must make a difference. But I don't. The previous meta-analyses included inflammation bowel diseases as well. So the colitis and Crohn disease, and that surely make a difference that we excluded them. But I don't know if endometriosis and colorectal cancer diseases would make a difference, because the anastomosis, the end-to-end anastomosis parts of the bowel is healthy in both of the cases. So I don't know.
I have the last questions. I think it's very important because I'm a surgeon, and all cases used sewing machine or others.
Yes, that's the other part of the limitation of the study for the surgery types, because some of them use sewing machines, some of them used hand sutures. So we couldn't make it like. We couldn't make a subgroup because they didn't report it. So they just reported the percentages of the surgeries, how many they did with sewing machines or with handmade sutures. But for the complication rates, they didn't report. But they didn't. So that's the problem. They didn't report the complication rates specific for the.
And what was the treatment, for example, in the leakage?
The leakage treatment?
Yes, for example, it has a leakage.
Mostly reoperation.
Reoperation, yes. Or drainage, or ileostoma, or what was the treatment?
The treatment, we didn't focus on that, because we just we just focused on rates. But
yeah, thank you so much.
That could be our next study. But
okay, thanks.